To do the panel moderation, please welcome Dr. Ranjan Nag. The best way I can introduce Ranjan is that he's the guy who got from MIT to the cover of Fortune magazine in the shortest amount of time. And beyond that, he's got an impressive resume you can read up, and then Ranjan, please take over.
Thank you. Can you hear me? Okay, thank you very much for attending this session. We're going to make this a pretty conversational session, but let me first give the backgrounds of my fellow panelists. So first of all, I have Anne de Geest, and she is Managing Director of Health Tech Capital. Thank you, Anne. So she's going to tell me how to make money. Then we have Divya Shroff. She's the Clinical Transformation Officer for HCA Corporation. And she's the actual only doctor, I think, on this panel. So, she's going to tell us how to fix the healthcare system. And then we have Marty Coruscant, who's CEO and founder of Telsano, which is a company that has invented a device where you can stand on and it tells you everything about you in a very short amount of time, and it won the Qualcomm M-Life prize. And me, my background is I start and sell companies, one to Motorola, one to BlackBerry, and I started to look at the healthcare industry as a industry to get into. So I get the chance to ask all my stupid questions that I was afraid to ask of my fellow panelists, and see, well, can you actually enter this industry now? It reminds me of the mobile industry 10, 12 years ago, where if you wanted to do anything mobile, you had to work for Motorola, Nokia, AT&T, and that was it. And about 10 years ago, people from other industries start popping up. You know, we're making mobile apps outside of the industry. And I see that in healthcare, that we're starting to see a lot of apps popping up. And they're from people who don't work for hospitals. They're not doctors. They're not specialists from that industry. So I'm going to start out with a softball question for Divya, I think. So why is healthcare so expensive? It's out of control. It's absolutely out of control.
I thought I was here to talk about mobility.
That was a softball?
You realize I work for a for-profit company.
For-profit, yeah. I think that
why is it so expensive? I think if you look at the recent CMS report that looked at the variation of cost of care, that's a huge component. I think the second part is our reimbursement model is in transition. Today, we reward for illness. As we move forward, if one were to read the tea leaves, we're going to be rewarding for health. And I think a lot of that transition or a lot of what we were doing previously has led to where we are today, and a lot of where we're going is also leading to, I think, a lot of costs being incurred because we're not sure how to get to that point. That would be my take as a physician.
And is technology going to help us? Is one of the thesis? One thesis is it's out of control because we don't know enough before the patient comes in, and if we can measure all these.
I'd say yes and no. So here's the reality, and I loved what the CIO panel said this morning. It's very easy to design a technology solution and not really think about how it all works. So, you know, the favorite component of clinical transformation, it's people, process, and technology. And it's very easy to think technology will not have to involve people and process. Well, at the end of the day with healthcare, you're talking about, for the true delivery, about 5-6 roles in the hospital setting or in the outpatient setting. And if you don't think about their workflow, how they're going to understand and utilize the tools, how they're going to engage with the patient, and even how the patient's going to function in that, it's not going to work. And so I actually sometimes think technology has been a barrier to that, because it's quite often my CIO or my IT teams will come into me and say, Dr. Schroff, we got the perfect solution. And they'll explain it out to me, and I say, wait a second, you've just spent all this money and it doesn't make sense. And I think there is that pause that needs to take place.
So Anne, you've got...
Yeah, I violently agree, and we just met, so we're still polite. So I mean, the big problem we see is that there's a lot of startups in the Valley or across the country right now, especially coming out of accelerators, who are really focusing on the technology and putting something over mobile is somehow going to fix it. And the biggest challenge of healthcare is defining the pain point. And healthcare is difficult to get because it's changing. The rules of engagement are changing. The payment system is changing. The physician used to be the center of the universe. That is changing. 60% of physicians now belong to an organization with their employees, and that's going to go to 80%. The whole decision-making process has changed. The biggest thing to decrease healthcare costs, which is what you asked earlier, is decrease the variability of care. And that's, you know, from the cost of imaging at $2,000 versus $600 to the way the physician treats you. And that is where, if you define the pain point and understand, you know, the payment system and the multiple stakeholder, people with veto power there, then the technology becomes an enabler to a solution instead of an end for all. And I think that's the big confusion in the space right now.
And so, I mean, there's this Qualcomm prize that's out there for, I'm not sure how many people you know about it. It's a $10 million prize if you can invent a tricorder. Those of you who remember watching Star Trek, it's a device where you just wave over you, and it tells you what's wrong with you, so you don't need any doctors, you don't need any nurses, it just tells you the diagnosis. And I'd like to sort of, maybe Marty could start, be the technologist here. Is that possible? Will we see that? I guess that's going to last for the next 2 or 3 years, that this competition is going to roll out.
I would say from a vision perspective, I hope it's something that we all believe is capable. I think someday, you know, that's where we should be aiming, is for the stars. Am I seeing something here today that's available? No.
Have you entered the competition?
I'm familiar with the competition, and there's several others out there as well. You know, it's combining, getting the data, number one. Number two, then putting it into if you will, a diagnostic engine for some type of decisioning before we then just carry it down in workflow through communications between the patient and the provider. It sounds simple, but you know, we hit that very first bump when we use the word diagnoses. And there's other members on the panel that can talk to that, but I think, you know, when we're held to certain criterion that we can't diagnose, suggest cures, those type of issues, and we've got to dance around that within the client experience, it puts us kind of on a tough edge to move things too much forward.
Yeah, the issue is called the F word, and in healthcare we call this the FDA. Please don't quote me. Spell her name, not mine.
I was wondering where you were going with that.
No, but that being said, I mean, it's interesting. So do we want to go there? And I say as a physician, I think the physician community is definitely, in some ways, fearful of that because they become a commodity and not the end-all, be-all. But the reality is physicians today are dealing with Dr. Google, where patients will come in and have come up with their self-diagnosis, WebMD, all of those things which do make a more informed consumer, i.e. the patient. But how you navigate between those components, I think, still needs to be discovered.
And Divya, do you think that's, doctors like 10 years ago, I think they were a bit perturbed when the patient would do their internet research first. I get the feeling, certainly with my doctor, she's actually now appreciative, because I can now have an intelligent conversation with her. I've researched this, and I'm using her as a filter for my research.
I think the medical community is starting to realize where they can be an enabler or an educator of the process. And I think as that matures, physicians will be more receptive to it.
Right,
but
and so
it's in transition.
this tricorder, if someone comes up to you, us technologists, we come over and say I come to Anne here, and so I've got this idea, and it's going to take 3 years, and the prize is $10 million, but I need $10 million first. Will you give me the money, please?
Well, I did talk to some of those, and I think the first discussion is that they were really
I'm
going...
not a doctor either, and
No,
I'm not medical.
I'll be nice. But the problem is that when you start making the diagnosis, is this where you end up passing a line that creates problems? problems. The first one is that the FDA will have very high requirements so that every time you make a diagnosis, it's repeatable, predictable. There's a very low false positive and false negative. And so the first application all these companies are developing are for babies at home. Well, you know, if your kid is screaming at 3 o'clock in the morning and it turns out he does have something very serious and is not being diagnosed correctly, there's a liability there. And the FDA doesn't want to pass that line. I think where we're going is some other business models that other startups have done, which is the high-tech, high-touch. And so, for example, WellnessFX is a company there. You can do your 30 biomarkers, and then you get a 15-minute telehealth with a specialist. And it could be a nutritionist, a cardiologist, a neurologist, whatever you pick. And then you have this personalized to you. And then you can act upon it now. There was a very interesting article that came out 2 days ago from the ex-CEO of Zeos. Who knows Zeos? You don't? Okay. So Zeus is the first big name in the industry that unfortunately didn't make it. And so it's always good lesson to be learned at the expense of other companies. And they were having a sensor that was an EEG sensor that gave you an indication of your sleep quality. And it was FDA approved. It was working. It was high quality. It was really doing the REM sleep and all the other things there. They failed after $30 million of money. And the CEO came back to say, listen, lesson learned. It has to be personalized to that person. There has to be a prescriptive advice. What do I do with that information? It has to be something that you do now, not in 5 years, 6 months. I mean, that's way beyond the consumer. And it has to be presented in the context of a clinical, you know, intervention there. So, so I think that that's the challenge. Is all these components needs to be met.
And then you talked about, you know, the FDA. Now, I read somewhere that on a lot of these smartphone apps, you see sort of apps that are sort of just crossing the line a little bit, you know, heart rate detectors, temperature detectors, and I read the FDA was taking a lighter touch to those. Is that true? Is that your perception as you see in the marketplace? For any of you?
I've had a discussion with the FDA team on that, and pretty much there used to be a law saying if you're an accessory to a medical device, automatically you become at the same level, which was an issue. So if they're class 2, which is, you know, require me to be some clinical data, automatically class 2.
So class 2 needs lots of testing.
Lots of testing and all of that. Class 3, then you can just forget it. Sorry, inside joke. And so it's the nuclear winter to get funding there. So what they have done is that they were supposed to issue the FDA guidelines, which is basically the rules of engagement. That was like over a year ago. They have punted again to the end of December. There's a lot of disagreement within the FDA on how to regulate. They have given guidance. Guidance doesn't mean it's the rules. Guidance means it's indication, which could change, that pretty much the hardware platform will not be regulated. So the iPhone, the iPad, all of those will not be regulated. It's the application itself. So that was the first clarification. The second one is that if you provide information for information use only, which is what a lot of companies are doing, and you don't pass the line of making a clinical diagnosis for disease, this is the line you don't want to pass, then they say we're going to let the market decide what to do.
So I'll just give you the heart rate data, but I'm not going to tell you anything about it.
Yeah, and so for example,
means.
AliveCore, I don't know if you know AliveCore, this is a device you put in the back of your iPhone 4, and you literally, you know, hold it between your left and your right palm, and it gives you EKG. Now, high quality EKG, so 1 lead EKG. So right now it's prescription only, and they are now working with the FDA to be able to go to the market. The question is that who does the interpretation of the data, what does it mean, and what do you do about it? That's why I think a lot of these companies end up with high tech, which is capturing the data, and the high touch, which is the interpretation and the action about it.
So
I'm going to add, there's one more challenge to that, though. So for those who might have been here when the panel started, there was a great commercial by Qualcomm, and they started with the healthcare angle, and they showed this woman wearing a device and how she spoke about, you know, her heart tracings going to her cardiologist. But the reality is, in that very nice commercial, is no one's working and thinking about how that integrates with then the vital signs that might be coming from a different device, and how does the provider who's getting now information from 5 different feeds into 5 different apps that give them a very fragmented view of their patient. And providers are going to push back on that, because if they have to be the high information, the one who has to interpret the data, they need that holistic component of whether it's the virtual patient or the live patient, of being able to see that in a way that is not more time consuming, but actually more effective and efficient for them to do better.
So Divya, you know, there's lots of devices. I've got a watch myself, it's called from Basis, and it collects all the heart rate, every heart rate, and historically when I go for a physical, they take my heart rate, And what if I came along, well, here's every heartbeat for the last 3 years.
Information overload.
Right. Well, let's assume it's collated in one place.
Sure.
But the question I've always asked is, well, doctors are not used to getting every heartbeat for the last 4 years. They're just used to that snapshot. Have we, A, got the research out there to know what to do with it, or B, can we actually take action on this data? We'll give you the whole thing.
I think there's two components, right? And even it's a little bit of what Anne spoke to and how we handle the cost. You're looking at variability, you have to look at big data. But then there's the second part, the translation or the transformation of, while someone, a data scientist or an analytics person, could look at that data and see the trends, how are we teaching our medical schools, our nursing schools, to look at it that way? Because I've only been out of medical school 10 years. And when I was still in there, and as I've been a teacher, you're still taught, look at that in that one point.
Right.
And
yes.
so, in a way, we even the technology sector could create these amazing tools, but if it doesn't infiltrate the way education's taking place and didactics, people aren't going to be open to that model of information gathering.
So we have to sort of change. If you're starting an entity, it's not just the technology and what it does, it's also a training and education process for the community, both the professional community and the patient community.
One of the biggest challenges we're facing is that we historically have trained physicians to basically wait for the patient to come to them in a crisis situation there where its life is on the line. You basically take a snapshot of what's happening at that time, you intervene, and then you patch them up and you discharge them and you hope.
And they're
they
trained
learn.
that way because that's how they get compensated.
I know, there's a fee for services. I mean, we are moving, and this is the biggest challenge in healthcare right now, into a transition where we're going, expect to do what's called capitation, which is all the providers will be paid, let's say, $200 per member per month, regardless if you're sick or healthy or in the hospital. Suddenly you're doing what's called population management. You start having to be looking at people looking forward. So I'm going to look at him, and I says, based on my population, my database, you have a risk factor of 4x to get a heart attack in the next 12 months. Now I'm incentivized to probably look at your EKG beat by beat and see if there's anything wrong. Where in the past, you were incentivized to wait for him to show up in the ER.
Right.
And the challenge right now for startup companies is that the payment system is still the old one. We know we're going to run new ones, but you get penalized if you have the new
And
one.
even
fix
for the
people.
healthcare delivery system, I say again, as the largest for-profit company, we are challenged with that every day, where we are watched on the stock market. We own 165 hospitals in this country. We take care of 5% of the population. We have to focus a certain way, but also be strategic on where things are going. I know you want to say something.
Yeah, but I was just going to say,
We'll
you
let
know,
you talk.
I have a question for Marty.
I guess I don't get to talk. Well, can I get a question?
Actually, I've got a question. So, following up on what Anne said, where we gave the AliveCore example, my understanding they started off with vets before they started off in humans. And in many of these medical apps and technologies, they start off in the health fitness segment, so it sort of avoids the FDA approach. And my understanding is you went full front and center with the FDA approach with your product. Can you give me the trade-offs? If you're trying to start a product, why would you start with the healthcare or the veterinary segment before you hit the human segment?
With Helsana, we've always been very specifically within the health segment. We've had a couple other startups that we've done that we did start within the vet area.
Is that easy? Is it easier if you start
It
with
was
animals?
on that type of product. It was a product in which we could dispose the sharp needles on site, eliminating the cost of having to have disposable services come to you and remove that. That product is gaining traction in the veterinarian area. It didn't require FDA approval, so from that perspective, it was just a kind of a nice way to get into a revenue stream quicker. On the health side, though, we got to be much more careful about what we try to do too quickly. We definitely want to make sure that we're building trust partners along the way, including the consumer. But one of the questions I would want to throw back to the doctor is do we consider the doctor's office a retail location? I've always been wanting to ask that question.
I don't think as much as we could. I think it has never been viewed that way. I think there's a lot of opportunity.
And I think this is, I was hoping for that answer.
Okay.
I think this is the one area, and Ann has alluded to it a couple of times here, and we are really starting to see the consumerization of the medical industry, and I don't think a lot of us really are taking that completely to heart and what that means. And it really means that the physician needs to have a continuous relationship, ongoing with the patient, and not one that is just kind of episodic, where we just visit them 1 or 2 times a year. And in that relationship, then, we need to be able to supply the doctor with the tools that they need when they need them. The same way that we handle our customers on the other end, and that is we're always dealing with our customers, providing them with the personalized information when they need it and where they need it. And we just need to combine those two together.
So you bring a very interesting point, because the role of the primary care provider is going to be changing drastically. So if you look from one extreme, you have Walmart, who is deploying 1,000 health spot booths, which is a booth, you go in there, it has a couple of sensors there, it takes your vital signs, maybe some diagnostics, and then you have a telehealth with a physician there, and then you get a prescription, you pick it up in the back of the store, and of course you pick up a few things on the way there. So that's one aspect. You have also other company like Facebook, Apple, who are bringing the primary care providers on site, creating the campus, the university campus there. That's on the high end. And I think what's going to happen is that, plus the telehealth and all those guys, most of the run-of-the-mill primary care provider services is going to be brought to the consumer wherever they are, which could be in their home, in their offices, or in the mall. And then the role of the primary care provider is going to evolve into this chronic disease management, this patient population management. The challenge is, how do we train all these physicians to think totally differently? Instead of managing 40 patients who comes that day for 6 minutes each, we're going to manage 2,000 patients, which is what they typically have in the practice.
But it's interesting because you alluded to telehealth, and I challenged someone who asked me about this recently. I said, that's true, and we are training our patients to think that way. But if any of us had a loved one who was in a healthcare crisis, would we be okay with that being the model? And in a family of physicians, when someone gets sick, it's all about how can I get in? I mean, so there is still that human contact, that point of real connection in healthcare that shouldn't be lost as we think about mobilizing this commodity. Maybe there's a new generation of people out there who, as they get sick, that's what they'll be used to, but I think there's a transition even there.
That, and as we look towards commoditizing, if you want to quite jump that far, and I guess when you start talking consumerization, you have to talk that in the beginning. But the point is that I think as we move there, develop the relationships, we don't always have to jump into the 20% use cases that scare the hell out of us. I think there are plenty of 40 and 60 and 80% use cases that when we look across the entire continuum of care, there's plenty of places for mHealth, digital health, innovation, period, to take place and not completely disrupt the current model while still starting to build these binding relationships that we need to build between our primary physician and us as a consumer.
And I couldn't agree more with that. There's an interesting company that I've been following, and I say this to a room of technical people. It's called CellScope, and I don't know if anyone's familiar with this company.
Yeah.
And so what they've done, I think, is genius, and it builds exactly on what you're saying. They've created an adapter to attach your iPhone for mothers or parents to look in their children's ear to see if their child has an ear infection. And, as anybody might know who has small children, that is a constant plague of having a child. You're always worried, are they tugging at their ears because they're teething, or do they have an ear infection? It's also probably the bane of existence for every pediatrician who is handling those phone calls and only really wants to see and treat the child who actually has the infection and give the antibiotic where appropriately needed. The neat thing what CellScope has done, at least in theory, is saying we're not necessarily going to make the true diagnosis. We're going to go through a bunch of big data, look at the image of that we capture of your child and see if it's otitis externa versus otitis media. And even if it's otitis media, maybe a little bit go further if it's a bacterial versus viral component. And then you should call your provider. I can't think of a single provider, as well as parent, who would not appreciate that sort of wellness mHealth touch. So I agree. I think I want to make sure, as we think about everything being mHealth, we don't forget about when people age or those acute crises, that's not always going to be the solution.
One of the challenges as an investor when we look at the CellScope is who's going to pay.
Great point.
And that's a problem of transition in healthcare right now. So as entrepreneurs, you should ask first the question, what's the pain point, what's your solution? But unfortunately in healthcare, who is the payer is not always straightforward. As soon as you start going into my child is sick, there's an expectation that the insurance industry will pay for it. And right now, that's not the case. And so that's the challenge of a lot of these companies, that they have really cool technology and they're not having traction because they cannot figure out the revenue models. And as a result of that, the investors are not coming behind it.
So Anne, in following up from that, then, I mean, there is a school of thought that the real market is the uninsured. People don't have access to doctors at all, either here in the US or overseas. Will we see a scenario where people just look at the web in an extension and look at their phones? It's got
Well, Mayo Clinic, I don't know, have you been following Mayo at all, Ann? So Mayo Clinic's done something really interesting. One, they've created a very interesting brand, which is Ask Mayo. And I recently heard their CMO speak, and he really hypothesizes that today at the Mayo Clinic, they may treat, even with their multiple centers, maybe a couple million patients at best. They, through their web-enabled YouTube videos, creating an actual brand identity, envision that they will more than do, double or triple that number by exactly going even international or just beyond.
Well, who pays that, and how do they afford it?
Good question. Good question.
That's always a good question. So in our case, I think some of these emerging countries create totally different type of problems and solutions that may not be relevant in the US initially, but we could get there. So for example, we invest in a company called PharmaSecure, who is going after the Indian market. I figured this is a good conference for that. And so it turns out in India, you may not know that, but up to 20% of the drugs are not correct. They're faked or they're diluted, and it is a big problem. So they went after the drug authentication market. So every drug has a code that's being put on the drug, and then using SMS text, because everybody in India has access to a phone, you could basically validate that. Now, if you think about it, you now get the cell phone, the name of the person, and what they are taking. So now you have the last mile, which we've been desperate in the US in getting there. Now you can push information to them. You can tell them, you're supposed to have your refill, is there a problem? And so that company started in India, and in India, one of the problems was having some of the Indian-made drugs were being sold in Europe that were faked, and unfortunately they were made in other countries, and the Indian government got really upset about that because it was hurting the reputation of the Indian pharmaceutical industry. So they passed a mandate saying in India, every drug made in India sold on the Indian market will have to have this type of drug identification.
And that increases the cross-border market for...
Yeah, and it suddenly created this whole big data gathering and all of that pharma industry is willing to pay for in multiple ways. So in this case, you're providing your services to a market that really couldn't afford it, but we found a way to get there using mobility.
So going back to the cost, I mean, a lot of people say, well, government's got to take on the expenditure of radical, revolutionary medical inventions. Now, we've just sort of gone through the multi-billion-dollar genome project, and I read a couple of months ago, the government has just started a seed project, $100 million for the brain mapping project. But I'd like to go back to the genome project. I mean, because there are people who invested in companies in that space. What worked? What didn't? Who made money? Who didn't make money? Either from a technology or patient practice or an investment?
Yeah, we probably all have opinions, so I'll start on the economic side, because President Obama made a statement which is controversial, which is, he says, for every dollar the government spends, which is $3.8 billion, we generate 140x return for the economy. Now, if you look at the math, the analysis was really the people who had a job working in that industry. So the $800 billion was really taking the salaries of the people who were working there. The true value of disruptive technology is the enabling, like mobile phone has created massive new markets. And so the problem of the human genome is that we've gone from $3.8 billion to you could get now your genome done for $1,000. So the good news is that it dropped faster than Moore's Law. And it's probably, a big breakthrough there from a technology side. The challenge is, what does it mean? Initially, when we look at the genome, we only decrypted 2% of it because we thought that was the only thing that matters. And of course, like we learned in science, the other 98% wasn't really junk after all. And so we're trying to figure out what it means. And we initially thought it says, okay, you have that gene, tough luck, you're not going to make it. and what we discovered, unfortunately, wasn't that clear cut. It was saying, okay, you may have your odds of risk going up from 5% to 6.7%. What does that mean? What do you do about that? I think is what we're trying to figure out is the meaning of it.
Yeah, absolutely agree with that. I think the key for us at Telsano as an aggregator of data, the key is that
I mean, there are a lot of dashboards out there. I hardly see any of them using any gene data. You know, 23andMe.
23andMe.
They have an API, you can upload it, but nobody actually seems to
they
use
launched
it.
their API almost a year ago. But it's definitely a matter of time for those players that want to play that aggregator role. For Telsano, it's definitely on our roadmap, but there's many priorities prior to that. And there's also some.
So you're saying
there's
it
some
doesn't
things we're
actually-
going to definitely have to consider before we actually bring in that API. Because I think from a regulatory and compliance perspective, I don't think there's much high risk there. I think the FDA classification is fine. But from a privacy perspective, because of the type of data it is, we want to take a secondary look at that. But also, it's episodic data. It's a one-time type of data, and that's where a really interesting conversation comes in. If we go back to the exit letter from Google Health, why did they say that they were exiting the industry? It's because of our data was not interesting enough that people would come and visit it. It was episodic
It's a one-time.
data. It was a one-time
It doesn't
snapshot.
change.
So obviously, our priorities are to deal first with the near real-time data and then make that meaningful. And making the data meaningful is what's important to the consumerization. And what Ann said is so important around genome. I mean, Telsano is not an expert in that.
But did people make money in supporting that program?
You had all the people making the tools. So Illumina, Affymetrix, Life Technology became really big company, but they developed a tool to do the analysis. Now the big thing with the hot area on startup side is that we take all these data over the clouds, and then we have to store them somewhere. That's the first thing, and secure. And then we have to analyze as we are learning what it means. So right now they take a piece of the genome called a SNP, and then they say, okay, that little piece there, what can I do about it? So one that could be interesting to all of you is that they have discovered, I did it to myself, and it turns out I have what's called a high-intensity metabolism, which is the only way I basically increase my metabolism is to really go for short bursts of very high-intensity exercise. The only way I figured this out after 50 years, I wish I had done this 20 years ago, is that I did my personal genomics, and they tell me this is what you have to do. And then because I knew the space, I did my own homework, and then I figured what to do with information because I was missing in the data. And so I think that's the problem right now, is to get something that tells me what I should do today, and then I get quick feedback that reinforces my behavior.
Right, so the brain mapping project, this is starting out. I should build a tools company. Is that
I mean,
that's
honestly,
the analogy, right?
I mean, I followed the brain for a long time for multiple reasons. I mean, we want to map 10 billion neurons that have 100 trillion connections there. Yeah. We don't even know how we're going to keep track of the electronics, and what does it mean? We don't understand how Alzheimer's works. After billions and billions of dollars, that company failed. So I think it's going to be a massive research program that maybe our children and maybe our grandchildren will usually benefit, and that's where I think there's going to be creation. It's going to be the people providing the tools and the instruments to manage that research. As far as this affecting our daily life and make us smarter tomorrow by picking a pill, that may take a few more generations.
Okay, and so on the technology side, is there any sense, I mean, I guess people are still taking blood pricks for glucose, but here things are popping up where things are less invasive. Are there any sensors that will be a breakthrough to really enable data collection?
I think
they're on the horizon. Nokia, by the way, has a 2.5 million prize on the X Prize for the sensor part.
You know, I think the industry is still dealing with power issues, just to be honest with you. I think these patches, the Band-Aids, I think are going to be an interim, long-term solution, which may be a swallowable or something that's under the skin or a tattoo. But the patches are there, but it's just as a matter of how long can they stay on and collect information, and then the type of information. But I think there's many new things coming down the pike. I'm just going to leave it there, watching the clock here on time.
Okay, any more comments? We're about to break for lunch. Anybody want to say any last thoughts from anybody on the panel?
Just the last thing, since I'm last to speak, I'll just finish up here. I think one of the things that at Telsano that we realize is that many of the physicians are experts in their domain. But when we start talking about the consumerization and talk about taking their practice and talking about it as a retail space, I think as entrepreneurs and business people, that's where we need to develop the tools to help these professionals to grow their business in an area that's changing.
And I think, to add on to that, I think it's an exciting time to be a professional in the healthcare world. The fact that there is this patch instead of something else. But they need to be a part of the solution, a part of the conversation, instead of it being tools that are thrust upon them either by the payers, by those who employ them, or by their patients, without them being a part of the conversation. More and more physicians are disenchanted with healthcare and are dropping out because of the solutions that don't really have practicality to their daily workflow. Does that mean that they don't need to change their workflow? Absolutely not. You know, as a profession, we tend to be the last to adopt technology. But that being said, for all of us who will eventually be in that aging group, we want to have that population of providers with us at the table, and I would encourage for all the developers out there to think about that as you think of
And you
solutions.
can have the last word.
So this is a massive opportunity right now. You have 16% of GDP that's being turned upside down. All the resistance to change, which was the biggest problem in healthcare, has been absolutely blown to pieces. So there's going to be massive companies that are going to emerge, all the way from changing the payment system to delivery inside the hospitals to delivery into the home. So it's a massive field that has opened up. My only recommendation is to make sure, don't think that putting something on an iPhone app is going to fix it. You really have to do your homework, but there's huge opportunity for very big company that are going to grow very fast. But you need to have the right team with you to help you to get there.
Excellent. That was a scintillating conversation.
Thank you, Ranjan. Thank you, panelists. I think they deserve a big round of applause for that one.